Hello, everyone, and welcome to today's webinar, Real-World Experience with T2Candida at a Community Health System. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by T2 Biosystems. To learn more, visit t2biosystems.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. And with that, I'd like to now welcome our speaker, Dr. Elisabeth Chandler, Pharmacy Clinical Specialist, Infectious Diseases, PGY2 Infectious Diseases Residency Program Director, Gulf Coast Medical Center, Lee Health at Fort Myers, Florida. For a complete biography on our speaker, please click on the Presenter tab. Elisabeth, thank you for joining us. You may now begin your presentation.
Thank you so much for that introduction. As mentioned, my name is Elisabeth Chandler. I'm a pharmacy clinical specialist, infectious diseases at Gulf Coast Medical Center, which is a part of a health system in Southwest Florida, Lee Health. I'm very excited to be with you today and to talk about the use of T2Candida at my health system. We have a few objectives to cover throughout the presentation today, and really I'd like to focus on some real-world patient cases that we see in practice, and these are patients that really have come into our health system, and so we will be describing the utilization of T2Candida at Lee Health. We will explore risk factors for invasive candidiasis in a few different special patient populations, and then we will also talk through optimizing patient outcomes through appropriate diagnostic and antimicrobial therapy management, which that's really why we're all here today. We're here to optimize patient outcomes and improve patient care. The key concept that I would like to highlight, and I'll refer to this several times throughout the presentation, is that rapid diagnostic technology improves patient outcomes. Like I mentioned earlier, we'll go through a few real-world patient cases. We'll talk a little bit about T2Candida and its impact on patient care. But taking just a step back from that for just a moment, technology is advancing. Diagnostics are getting better, they're getting faster, even with the recent developments in healthcare and, who knows where AI is going to take healthcare in the next 10 years, right? But really the focus here is that with technological advances, including rapid diagnostics, it's all centered around improving patient outcomes and patient care. So that's why we're all here today, and that's what I'd like you all to keep in the back of your mind as we go through this presentation. So context is key. I wanted to provide a little bit of context of the healthcare setting that I practice in, because I know many of you may come from different areas of practice, different backgrounds, different professions. And so just to set the stage of these real world experiences, I'd like to tell you a little bit about our health system. So I practice at Lee Health, which is in Fort Myers and Cape Coral, Florida, Southwest Florida on the Gulf side. We are a large community health system in the area, and we have 5 acute care facilities. So that is 4 adult hospitals as well as 1 children's hospital with around 1,800 total beds. We see a variety of different patients and different types of services, both inpatient and outpatient, but the Southwest Florida area has really been expanding, not only patient population-wise, but also our services have really aimed to keep up with the growing patient population here. So we've had a number of recent expansions, including our level 2 trauma center. We've had some expansions to 2 of our hospitals of our ICU beds. And then most recently, we we also opened a new oncology unit. So we're expanding our oncology patient population through the Regional Cancer Center. So though we are a community health system, we see quite a wide range of different patient populations and needs in our area. And so we really try to all work together to keep up with the diagnostic and therapy related needs for those patients. My primary area of practice is in working with our antimicrobial stewardship program. Now, just to give you a little bit of background, our stewardship program is a really big umbrella of different healthcare professionals, all working together to optimize therapy for patients with infectious diseases. We aim to decrease the growth of bacterial resistance and fungal resistance, and then also prevent hospital-acquired infections and so many different things in between. It truly does take a village with the patient at the center of it all, but just to name a few, we work with our providers, our nursing partners, especially the collaboration with our laboratory and microbiology colleagues. That is so incredibly important in appropriately diagnosing patients who have severe infections. Now, we also work with our leadership to garner support for new initiatives. Our pharmacy team, which is my primary background, infection prevention, information systems, and environmental services. Every player of the team, and this list is not all inclusive, but every player of the team is important, and we collaborate together in a lot of different initiatives to move healthcare forward and really improve patient outcomes for Southwest Florida patients. When it comes to the collaboration between antimicrobial stewardship and our laboratory services, as well as microbiology, there's a number of different ways in which we work together and collaborate together. A few that I'll point out, one of which being diagnostic stewardship. So there are many labs, but our labs are only as good as the builds that we have for those labs, the education given, the appropriate processing of the labs, and then the people that we have to respond to laboratory results. So there's a lot of different players that go into diagnostic stewardship and ensuring that we are not overutilizing or underutilizing certain diagnostics. We certainly work with our microbiology colleagues to work through antibiograms, which really give us a fantastic global picture of what our resistance rates are looking like at Lee Health. Selective cascading being how we are releasing different culture results, whether we hide certain antibiotics or antifungals or certain ones that we release. Rapid diagnostic testing, which really is the central focus of this presentation today, and making sure that we're implementing and educating on appropriate use of rapid diagnostics. Susceptibility testing, providing result comments or nudges to say in the electronic health record to help guide prescribing, and as well as education. So hopefully that provides you all with a little bit of background on our health system, the type of services that we provide, the patients that we see. And so I would really like to move into talking about candidemia and invasive candidiasis. Just to provide a little bit of background on candidemia as a whole, it's truly a very impactful disease state, as it is the fourth most common cause of nosocomial bloodstream infections in the US. It's associated with a high morbidity and mortality in the ballpark of 40%, but I've read a number of reports with varying rates of morbidity and mortality for patients. And while 40% I think is a pretty solid marker, I've seen certain reports as high as 50 or 60% in specific patient populations. So really an impactful disease state when it comes to patient outcomes. The other thing that I'd like to mention with candidemia is the most common manifestation of invasive candidiasis. But there's a problem here. So the diagnosis of invasive candidiasis and candidemia actually poses a number of different challenges to the clinician. Blood cultures can be negative in about 50% of candidemia cases. And so these invasive infections are really challenging to diagnose at a baseline with our traditional culture methods. I also think this is particularly important as we keep in the context of the fact that healthcare is advancing, technology is advancing. These days, we have more and more patients who are receiving immunomodulatory therapy and immunosuppressive therapies. There are more patients walking around with central catheters and who might be at higher risk for more invasive infections such as candidemia. So I think while this paints a really good picture right now, I think as healthcare continues to advance for the benefit of the patient, we also are going to continue to see an increased patient population who has some of these risks or comorbidities. As I mentioned at the start of this presentation, I really think that real-world patient cases help to drive home the impact of invasive candidiasis and candidemia. So I have a few cases sprinkled throughout this presentation. So starting off with the first case, we have a 75-year-old female who presented to our hospital with abdominal pain and hypotension. She had a significant past medical history, just to highlight a couple of notable ones being a history of ovarian cancer with metastases. She is PEG and TPN dependent, and so she does have a indwelling central line. She also has a history of hypertension, hyperlipidemia, and type 2 diabetes. This patient presented to our hospital after a very recent discharge after a prolonged hospital stay. So she was here for 3 weeks, was discharged, and then unfortunately came back. And during that 3-week hospitalization, she had several GI surgeries, with the most recent and most notable being a bowel resection after a duodenal perforation. Whenever she presented to our hospital, there were a number of consultants on board, including surgical oncology, GI, and infectious diseases consultants. So in looking at this particular patient, what risk factors does this patient have for candidemia and invasive candidiasis? I will pause for just a moment here so that you can think about this question. There are a number of important risk factors for invasive candidiasis, and I think something to keep in mind is the fact that these are typically additive in nature. So not every patient who presents with either sepsis or a central catheter is necessarily going to be at risk. However, especially patients who have numerous risk factors for invasive candidiasis. The first one being GI tract alterations. And so this can especially affect patients with malignancies, including hematologic malignancies or those undergoing active chemotherapy who have that mucosal damage to the gut. And then patients who have experienced recent abdominal surgeries, as the case that I just reviewed, are particularly at risk for invasive candidiasis. Just to point out a few other notable ones, so patients who are receiving immunosuppression, so those with malignancy, history of transplant, or who are on long-term immunosuppressive medications. Like I mentioned earlier, this is becoming increasingly prevalent in our patient populations today. Patients who are TPN dependent, and especially those with central venous catheters, are at risk. Patients presenting with critical illness or who have sepsis or septic shock are also at risk. And then patients with a history of prior broad spectrum antibiotic use, as well as significant healthcare exposure. So the patient that I just mentioned just had a 3-week hospital length of stay. She did not receive significant broad spectrum antibiotics during that length of stay. However, she did receive IV antibiotics for surgical prophylaxis for several of her GI related surgeries. And then lastly, Candida colonization. And typically this is in a higher association with multifocal Candida colonization, so in several different sites. And then I won't dive too deep into COVID-19 at the moment, because we'll talk about that a little bit later on in the presentation. But there have been some interesting associations with COVID-19 and development of invasive fungal infections. So this list, I think, really does a great job in capturing some of the risk factors. And the patient case that I mentioned, she had a history of malignancy, recent abdominal surgery, on chronic TPN, central catheter. She presented with hypotension, not necessarily sepsis, but significant healthcare exposure, and some IV antibiotic use from surgical prophylaxis. So she really did check about 5 or 6 of these boxes here as far as risk factors go. Now, moving along with her case, a couple of interesting notes here. So on the presenting urinalysis, she had many yeast present. Now, the urine cultures and the blood cultures ended up being negative. However, the ID consultant who came on board right when she presented to the hospital also ordered a T2Candida in conjunction with the blood cultures. The T2Candida ended up returning positive for Candida glabrata and or Candida krusei. Now, this case was particularly interesting because the blood cultures were actually negative. So whenever that happens, there really has to be a clinical assessment and clinical judgment of the patient to determine whether this patient truly does have a candidemia. Now, based on the fact that she was at extremely high risk for candidemia, this T2Candida positive was interpreted as a true positive candidemia, and so she was appropriately initiated on piperacillin tazobactam for suspicion of intra-abdominal infection, as well as micafungin to treat her candidemia. This patient in particular, I think this positive result is pretty impactful, especially with her initial blood cultures being negative. Even though she was at very high risk and initiated on micafungin initially, if the T2Candida was not ordered, it's very possible that the micafungin may have been discontinued in a day or two after the negative blood cultures resulted. This patient in particular, I think, really highlights the importance of time to initiation of appropriate antifungal therapy. This particular study is one of many, but really I think just does a great job highlighting the fact that there are patients with candidemia where every day, so these authors did a multivariate analysis, and every day that we wait to start appropriate antifungals, mortality increases. So you can see the graph on the right, the culture day on the x-axis with day 1 after culture, day 2 after culture, and day 3 after culture, that fluconazole is initiated for patients. On the y-axis, you can see the increasing percent mortality for each of those days that there is a delay in starting antifungal therapy. So this particular study and several other studies have demonstrated this as well, is that early initiation of antifungal therapy is associated with significant reductions in patient mortality. So that really ties us back to our key concept, right? We know that these rapid diagnostics are helping us improve time to identification and also time to initiation of antifungal therapy. 70% of today's medical decisions depend on laboratory test results. That is a huge number in regards to just the overwhelming impact that appropriate diagnostics will have on patient outcomes. So in order to influence outcomes, a laboratory test not only has to be ordered appropriately, so there has to be education and awareness of that particular lab. The test has to be conducted and performed. The results have to be returned and reported appropriately, as well as interpreted by the receiving clinician to affect a decision point for diagnosis. And so I think this point really aims to highlight the impact that diagnostics can have. Keeping in mind some of those key concepts, now I'd like to dive a little bit deeper into the T2Candida diagnostic. The T2Candida has really changed the game quite dramatically when it comes to detecting patients with candidemia. So the T2Candida uses magnetic resonance to very rapidly detect selected Candida species in whole blood. And the thing I'd really like to point out is that when we're talking about whole blood, we are not having to wait on the traditional blood culture methods before running this rapid diagnostic. So when this is ordered on a patient, whole blood is taken and results are available within 3 to 5 hours. So decreasing time to appropriately diagnosing a patient with candidemia is really quite impactful here. The other thing I'd like to mention, and I'll highlight this a little bit more later in the presentation, is that the T2Candida technology is not inhibited by prior antimicrobial administration. I think this is of particular importance, and we really try to do a good job as clinicians to make sure that we're collecting blood cultures prior to administering systemic antibiotics. But this can pose some challenges, especially in patients presenting to the emergency room who have sepsis or septic shock. There are many initiatives going on in the world of sepsis right now, ensuring that patients are receiving optimal therapy as quickly as possible, ideally within an hour of presentation and identification of sepsis or septic shock. And so the fact that the T2 technology is not inhibited by prior antimicrobial administration really helps us out in cases where a patient may have received antibiotics or antifungals prior to collection of blood. So I previously mentioned a little bit about the community health system that I practiced in, and this particular paper did come out of Lee Health. Now, this was prior to me joining the health system. I joined Lee Health in 2019, and so this report was published prior to then. So unfortunately, I can't totally speak to the rollout of T2Candida at our institution, but I can speak to some of our experiences over the past several years. But I really wanted to highlight this 2018 paper by Megan Patch and the team here at Lee Health. This was a retrospective analysis in 39 patients, so really a pilot study looking at the impact of T2Candida at a community health system. Not to go into too many details, but this retrospective analysis did show a significant decrease in time to appropriate therapy in the T2Candida group. And so that was a difference of 34 hours versus just 6 hours in the T2Candida group. If you recall just a few slides ago when I presented that graphic of every day we are waiting and not appropriately treating candidemia, patients' risk of mortality increases. So you can see even in such a small sample size, there was around a 24-hour difference here in decrease in time to appropriate therapy. So that's basically a whole day that we are improving patient care and improving the ability to administer appropriate antibiotics and antifungals in patients. Additionally, empiric antifungal therapy was avoided in 58% of T2 negative patients. Antibiotic stewardship has a lot of research and efforts going into it, but I think historically antifungal stewardship and antiviral stewardship has lagged just a little bit behind. And this is important because we are seeing emergence of Candida resistance. We are seeing, Candida auris is on the rise. And so stewarding and appropriately using our antifungal therapies really does need to be at the forefront of our minds as clinicians. Over on the right-hand side of this slide, I have the organisms that are identified on the T2Candida panel. So this is a highly sensitive and specific test that can identify one of these 5 most common Candida isolates. So Candida albicans, tropicalis, krusei, glabrata, and parapsilosis. Like I mentioned, many of these patients who have multiple risk factors for candidemia, whether they are immunocompromised or presenting with critical illness, a number of the risk factors can be additive. And so really every hour counts, especially in patients who are presenting with sepsis and septic shock. So just to highlight a couple of additional key points, the T2 technology is really the first and only FDA cleared diagnostic test for the ID of bacterial and fungal pathogens direct from whole blood. And on the next slide, I'll talk a little bit more in detail about how that process is laid out. So this is very, very fast, 3 to 5 hours from that blood draw, which really has enhanced the standard of care. And so most of our systemic antifungals that we're going to be using, such as an echinocandin, are dosed every 24 hours. So that means that the T2 panel will result and come back before you ever even need to give the second dose of empiric therapy. So this is a win in a number of ways. This is a win in not only antifungal stewardship, but also in faster identification of Candida species. And then the last box here, why does this matter? So the key concept we've been referring to is that rapid diagnostics improve patient outcomes. So patients who are presenting with multiple risk factors and who may have sepsis or septic shock, the T2 panels really do enhance the care that we can provide to these patients. So just to orient you to this slide, I'd like to first draw your attention to the blue bar that says blood culture. So this blue bar is the representation of traditional blood culture methods. So when blood cultures are collected from patients, it typically will take around 1 to 5 days for that blood culture to detect growth. From there, a gram stain is completed, and then there may be certain other rapid diagnostics utilized, such as MALDI-TOF, for example. And so really the key here is some of those other PCR-based rapid diagnostics or something like MALDI-TOF, they still hinge on blood cultures being positive. Now, I'd like to draw your attention to the orange bar up top. So the T2 technology changes the game here. We do not have to wait several days for blood cultures to return. We can draw the T2 from whole blood and have results in 3 to 5 hours. So you can see in certain patients, there are even several days, that we could potentially save this patient in regards to whether it be starting appropriate empiric therapy or performing appropriate antifungal or antibacterial stewardship. So the gray bar on the bottom demonstrates that. You can see day 1, empiric antibiotics or antifungals may be started for the patient, but because of the fast result of T2, they can be either escalated or de-escalated prior to that second dose of empiric therapy. So there could really be multiple days of therapy that we are saving patients. And so that's good for a number of reasons. When we're appropriately stewarding our medications and our resources, you're decreasing the risk of adverse effects and any downstream effects of antibiotics and antifungals. Additionally, highlighting this meta-analysis of 14 studies. Now, this is a meta-analysis looking at both T2Candida and T2 bacteria, so just keep that in mind. But just to highlight a couple of the key results that the authors found here, the first being faster time to detection. So when T2 technology was used, the time to detection was 81 hours faster, and time to species identification being 77 hours faster. And like I mentioned, this is a meta-analysis of 14 controlled studies, and so this is a relatively great sample of patients. The second point here is that targeted therapy was able to be initiated sooner. So patients who tested negative for T2 were de-escalated 7 hours faster. And those who tested positive on T2 received targeted therapy 42 hours faster. Like I mentioned earlier, there are certainly limitations when it comes to traditional methods of blood culture testing. And so the T2 technology can really help that targeted therapy, whether it be a de-escalation or an escalation for patients. And so that's a win for the patient. That is a win for stewardship. That's a win for the whole healthcare team. And then lastly, I know many institutions are experiencing this across the country, but reduced length of stay and working through transitions of care, I think is of particular interest in the healthcare field. There are many services expanding, including telemedicine, and how can we increase access to care? How can we decrease the amount of time that patients actually have to physically stay in the hospital? We know that the longer a patient has a hospital length of stay and the longer that they're here, they're at risk for hospital-acquired infections. And so what can we do to reduce length of stay, reduce the burden and the cost of the healthcare system? And so this particular analysis found that the length of ICU stay was 5 days shorter with T2 technology, as well as the length of stay being 4.8 days shorter with T2 technology. So I think this really gives some pretty compelling evidence that not only are we going to impact patient care positively, but when you look at the global landscape of healthcare and the care that we're able to provide for patients, this really can be quite important. So bringing us back to our key concept that rapid diagnostic technology improves patient outcomes. So far, we've reviewed this through some published literature, through a few real-world patient cases, and so I'd like to continue highlighting this discussion with an additional patient case. Now, I know that we are all probably tired of hearing about COVID-19 at this point, but practicing in the hospital as a clinician, we unfortunately are still seeing COVID-19 patients admitted to our hospitals every single day. The landscape of COVID is certainly evolving, but I really wanted to highlight this particular patient just to add some more recent information to the discussion. So this particular patient was an elderly male admitted to the hospital with PCR confirmed COVID. He had past medical history, including type 2 diabetes as well as hypertension. And when he presented, he had a relatively straightforward COVID presentation. So he was requiring oxygen support. His initial chest x-ray showed bibasilar infiltrates, and initial blood cultures were negative. So this patient presented with COVID-19 pneumonia to our hospital and was admitted for care. So initially, and this was a patient in the spring of 2020, so we were still using convalescent plasma in patients. He was given methylprednisone and azithromycin, and then he was also receiving 1 dose of tocilizumab, which is an immunomodulatory therapy that's recommended for the treatment of COVID-19. On hospital day 3, his status declined and he was intubated and transferred to the ICU for worsening respiratory status. And then on hospital day 14, this patient developed a new fever. The chest x-ray showed increased opacities, and so antimicrobial therapy was initiated for suspected bacterial pneumonia on top of his COVID-19. Now, despite the antibacterial therapy that was initiated on hospital day 15 and day 16, his fever continued to escalate. So hospital day 16, on this day, this is where additional blood cultures were collected, as well as a T2Candida, given the fact that he was continuing to clinically decompensate while already in the ICU, intubated, and on broad-spectrum antimicrobial therapy. At 15:47 on day 16, the T2Candida resulted with Candida albicans or Candida tropicalis. And so that was actually 29 hours prior to the blood culture returning positive for yeast on the evening of day 17. So because the T2Candida returned so much quicker than the traditional blood culture, the same day the T2 was ordered, we were able to start the appropriate antifungal therapy for this particular patient. On day 18, the PNA fish result was positive for Candida albicans or Candida parapsilosis. And then on the evening of the 18th, the patient did finally defervesce. And then lastly, on day 20, you can see that Candida albicans, the full susceptibility report resulted. So I think this timeline really gives a clear picture of not only the risk factors for this patient, but also the fact that the T2Candida allowed us to appropriately escalate his therapy and add on antifungals much faster, a little bit more than a day faster than traditional blood culture methods. Over the past several years, there have been a number of reported publications putting together the risk of invasive fungal infections and patients with COVID-19. There's a number of different theories here of why this is, but just to name a few risk factors that patients with COVID-19 who get admitted to the hospital inherently have, the first of which being the use of immunosuppressive agents. So if you look at national guideline recommendations for the treatment of COVID-19, one of the mainstays of therapy for hospitalized patients with severe disease are glucocorticoids. Additionally, patients who have rapidly decompensating respiratory status, as well as those who are requiring higher levels of oxygen and who have signs of systemic inflammation, it's recommended for those patients to use immunomodulatory agents such as tocilizumab or baricitinib. Now, both of these can be immunosuppressive, and it's recommended in many severe COVID patients that they are used in conjunction together. So patients admitted to the hospital at a baseline are at potentially increased risk. Additionally, patients with COVID-19, depending on the course of their illness, and I think this was also represented in the case that I just reviewed, have a longer ICU or hospital length of stay, depending on if they are slow to clinical improvement or not. And then lastly, patients who are admitted to the ICU with severe COVID may have a longer duration of mechanical ventilation. If they develop a secondary bacterial pneumonia or ventilator-associated pneumonia, this could also put a patient at risk for increased Candida colonization. So there are a number of risk factors that tie candidemia and COVID-19 together. And so, like I mentioned, I think it's still so prevalent in the community, and we're going to continue to see these patients as time goes on. So earlier in the presentation, I talked a little bit about our health system and the types of patient populations that we see. So I thought it would be important to review a little bit about how we use it at Lee Health, how we are educating prescribers, and just what it really looks like at a large community health system. So the original go live of T2Candida at our institution was in 2015. And really, the point that I want to highlight here is that it's not necessarily going to be a one-size-fits-all approach when it comes to the recommended utilization. So really, the use of rapid diagnostics such as T2Candida should ideally be based on your specific patient population, the type of area that you practice in, the type of patients you see, the risk factors that may be more prevalent in certain areas of the country and in certain locations. And so just to make that point, because I will talk a little bit about how we use it and the education provided, but just keep in mind that it's not going to be a one-size-fits-all approach here. So currently we have the T2Candida available for ordering by our critical care, oncology, and infectious diseases providers. At this time, we do not have ordering privileges for our emergency medicine providers. However, there really is great collaboration between our emergency medicine providers and our ID and ICU providers. So anytime an EM provider does have a high suspicion that a patient may have candidemia or invasive candidiasis, we always have an ID provider on call, as well as we have 24/7 ICU providers who are covering here. So I can also recognize that there may be different areas or other institutions that do not have consultants available so readily. And so the appropriate use and diagnostic stewardship, I think, should be tailored to each individual healthcare facility. This is some guidance that's provided to our clinicians on suggested patient populations to order a T2Candida in. So patients who have an elevated temperature or a significantly decreased temperature, plus patients who have particular risk factors for candidemia or invasive candidiasis are listed here on the slide. We have it broken down by patients who are either immunocompromised or non-immunocompromised. We know that, especially at my own center, we have an expanding oncology patient population. And so patients who have those malignancies or have a history of immunosuppression or corticosteroid use, certainly there should be a consideration there. Additionally, in non-immunocompromised patients, especially our ICU patient population, we've done some particular education for our ICU providers in recognizing if we have patients who are admitted to the ICU, perhaps they're mechanically ventilated, and they continue to have either fevers or clinically deteriorate despite receiving broad spectrum antibiotics, then candidemia or invasive candidiasis, we really should be thinking of that in the back of our minds. A few other risk factors that I mentioned earlier in the presentation on the slide here, central lines, as well as GI perforations or GI surgery and TPN. With any diagnostic, I think it's always important to understand the limitations here. So there is some degree of cross-reactivity with other Candida species. And so just keeping that in the back of our minds that any diagnostic is going to have a limitation. And then lastly, thinking through potentially invalid results. So there are a few different conditions or medications such as ferriheme, lipid emulsion, or MRI contrast agents that could potentially produce an invalid T2Candida result. And really what that means is that that result cannot be clinically interpreted. And so if there is a high suspicion of candidemia, we can absolutely order and run another T2Candida, and so just something to keep in mind. Additionally, I just wanted to again highlight the fact that in vitro studies have suggested no negative impact of antifungal therapy of therapeutic concentrations of T2Candida. So again, this is particularly important because we do know that traditional blood cultures are impacted. Over the past year or two, we've definitely done education at our institution for both our pharmacists as well as our providers, specifically our infectious diseases and our ICU providers. And so, as mentioned, I just think it's a really important highlight to know that any diagnostic is only as good as the people ordering them and the people interpreting them. So, education along with any new initiatives or any institutions who are thinking about rolling out the T2Candida certainly should be considered. So that brings us to our last case here. An elderly female presents with hypotension, fever, left toe purulent drainage, and suspicion for osteomyelitis. She has a past medical history of being nonverbal, type 2 diabetes, hyperlipidemia, hypertension, DVT, blood transfusion dependent, and she also has a Mediport. Now, this particular patient, just moving on to the next slide here, she did not look very high risk for candidemia at a baseline. Now, she certainly had a central line, but the initial working diagnosis was a diabetic foot infection. However, she did have hypotension and fever, and so blood cultures were collected, and on day 2, traditional blood cultures resulted with Candida tropicalis. Now, though broad-spectrum antibiotics and micafungin were initiated, she was slow to clinical improvement. And so hospital day 3, another set of blood cultures were collected, as well as the T2Candida, which ended up being positive. Now, this is particularly important because this patient actually was slow to clinical improvement. And so the positive T2Candida really prompted the additional search for source of infection and investigating why she may be slow to clinical improvement. And so on hospital day 4, she had her Mediport removed because that was now the working potential source of her candidemia. And then on hospital day 5, her T2Candida and blood cultures returned negative. So I think this is a unique use of the T2Candida in monitoring patients for clinical response and blood culture clearance that can certainly be applied, and we've used it this way at our institution. Just to highlight a couple of final points here as we conclude the presentation. As many as 80% of sepsis deaths could be prevented with rapid diagnosis and treatment. And so I've mentioned that rapid diagnostic technology can improve patient outcomes. And so especially patients with sepsis and septic shock who are at high risk, there's really impactful information that these rapid diagnostics can improve our patient outcomes. A few key takeaways to leave you with. So a few points that we've highlighted this presentation are that early identification of risk factors for invasive candidiasis. They can prompt appropriate diagnostic workup, so education and identification of risk factors. Additionally, rapid diagnostic technology, this can improve the sensitivity for positive detections over just blood cultures alone. So traditional blood culture methods are certainly limited, but rapid diagnostics can help us enhance patient care. And then lastly, time to initiation of antifungal therapy will directly impact not only patient outcomes, but also things like hospital length of stay and the healthcare burden overall. A few future directions at my own institution that we're looking into is evaluating the impact of T2Candida in our growing oncology patient population. We're also looking into evaluating the utility of T2Candida for blood culture clearance. So in patients who may be slow to clinical improvement, who do have repeat negative blood cultures, is there a role for the T2Candida in this situation? And then lastly, continuing our educational initiatives regarding the appropriate utilization of T2Candida in our patient populations. I want to thank you so much for the time and attention and attending this presentation. I'm really passionate about this topic, and so I just want to thank everyone for today, and I would be happy to take any questions at this time.
All right. Well, thank you so much, Elisabeth, for your informative presentation. We will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. We've already got some great questions coming in here. Elizabeth, this first question I have for you has a few parts to it. And this question asks, is Lee Hospital Pediatrics using T2MR for infants? Is the amount of blood needed from the young patient an issue? I understand the use of T2 systems is still pending for pediatric applications. Is this an issue for the hospital?
Yeah, that's a great question. Thank you for that submission. So, a couple of thoughts on that. So, currently, the T2 is not FDA approved for use in pediatric patient populations. However, it has been submitted for approval. At my own institution, that being said, we have used the T2 Candida in specific pediatric patient populations. However, I can fully relate to the fact that the amount of blood needed for running this diagnostic is always an important consideration. We have some really fantastic pediatric ID providers. So in the past, when we have made the decision to use the T2 Candida in pediatric patients, especially infants, it's always a careful risk versus benefit decision in regards to the blood draw for the patient. So we have used it in pediatric patients. It's quite a bit more infrequent than the use that we're seeing in our adult patient populations.
Great, thank you, Elizabeth. All right, next question here. How is the clinical team informed about the results?
That's a great question as well. So, currently at our institution, we have a process for our microbiology lab. So, whenever there is a critical result, which includes rapid diagnostics as well as sterile site culture results, there is a process for the micro lab actually calling out that result to the patient's nurse or the provider based off of the time of day. Separately from that, also, we do have a system in place for positive micro results that do go to our pharmacy team. So we have 24/7 coverage within our electronic health record of responding to those results from our pharmacy teams on all of our shifts. So that has been a really excellent process, and we've seen a lot of success with it.
Great, thank you. All right, another question here. Were you involved in pitching T2 to the lab and or leadership, and how did you approach gaining their support?
That is a great question. So I was not involved in the initial pitch. So T2 rolled out at Lee Health in 2015. However, I think there are a couple of important points to think about if there is an institution that does want to pursue rolling out T2. So there has been some data documenting the economic impacts of not only rapid diagnostics, but also cost savings and cost avoidance associated with the T2 systems. The other thing that I'll mention is that there's also published data on decreasing not only ICU length of stay, but also overall hospital length of stay. I know the landscape of healthcare is always changing, and something that I know many of us are probably seeing are that, decreasing the cost to the healthcare system and looking for initiatives for cost avoidance. I mean, those are really highly impactful, and so we're always looking for ways to improve, patient transitions of care from that regards. So those are a few different things I would highlight in support of rolling out this rapid diagnostic. We know at the end of the day, I mean, time is money, right? So if we're able to really improve patient outcomes, get them on targeted therapy faster, we can potentially decrease hospital length of stay and provide some other more positive outcomes for patients.
Great, thank you. All right, we've got time for a few more questions here, so we'll continue. This next question asks, how would you justify the value of the test to your leadership team?
Yeah, that's a great question, and I think a few of the things that I mentioned in the previous question probably apply here as well. So in justification of the test to the leadership team, I think the first thing to point out is the data in improving patient outcomes, right? We're getting them on targeted therapy faster, and especially in the setting of negative T2 results, we can actually de-escalate antifungal therapy quite a bit faster as well. So whether the result ends up being positive or negative, it's really a win on either side. From there, also, I think from a financial perspective, again, I would just highlight the impact that T2 can have at improving or shortening patient hospital ICU as well as hospital length of stay, and just trying to provide initiatives that contribute to some of that cost avoidance.
Great, thank you. All right. Next question here. Are you able to do anything differently regarding patient care for some of the results that come back negative?
Yeah, so in patients who appear to be at risk for candidemia, or maybe they have a couple of risk factors, but the T2 comes back negative and blood cultures come back negative, we are able to de escalate if there was empiric antifungal therapy started for that patient quite a bit faster. Like I mentioned in the presentation, so traditional blood culture methods alone can take anywhere from 1 to 5 days. So it could be hospital day 4 or 5 before the team may really feel quite comfortable and confident discontinuing empiric antifungal therapy. So I think, especially in T2 negative patients, that's really a win for antifungal stewardship.
Great, thank you. All right. Now, next question here. In cases where blood culture is negative, but the T2 Candida test is positive, do you trust the T2 Candida result?
Yeah, that's a really great question. So, anytime you have a laboratory test, right, we should always be treating the whole patient. Any lab can be useful in regards to the appropriate diagnosis. However, we also have to clinically interpret that result. So, oftentimes in cases where the blood culture is negative, but the T2 Candida is positive, we have to look at the patient, right? If they came in with either sepsis or septic shock, if they have significant risk factors for candidemia or invasive candidiasis, oftentimes there could be a couple of reasons why the blood cultures may be negative and the T2 Candida is positive. Perhaps the patient already received an antifungal prior to collection of those blood cultures, because we know that that can really affect the accuracy of the blood cultures, but it does not have an impact on the T2 result. Additionally, it's also very possible that it could be maybe simply just a lower inoculum infection that the blood culture is missed. They're only about 50% sensitive for detection there. So there's a few different things to think through clinically, but as far as trusting the result, I would certainly trust the result. But of course, any laboratory test should be interpreted in the context of what's going on with the patient overall.
Thank you, Elizabeth. Looks like we have time for one more question here, so we'll conclude after this one. This question asks, T2 has been working on a resistance panel to pair with their pathogen detection panels. How do you see that panel affecting the adoption of this technology?
Yeah, that's a really great question. So most of the focus of this presentation was on T2 Candida, but you're right, there is also currently approved the T2 bacteria, and then in development is the T2 resistance panel. I think some of the specific resistant markers, especially for some of our gram-negative resistant infections, it's really going to drive practice change in the future, especially with this technology being utilized on whole blood. I think it can really improve the time to optimal therapy in patients with multi-drug resistant infections. Another thing that I'll just mention, and this is very fresh on my mind as we're currently building our own specific institutions antibiograms for this year, is we have seen a pretty steady increase in our multi-drug resistant organisms, including our carbapenemase producers. So I think, there's many institutions right now that may be considering implementing or rolling out testing for some of these specific resistant markers. But I think that's where we're going to be going in the future is, earlier and more rapid detection of resistance markers to ensure that patients are on some of our more novel therapeutics against those organisms. So I think it's going to change the game as resistance continues to increase.
Right. Well, that will conclude our session for today. So we want to thank you again, Dr. Elisabeth Chandler, for your time today and your important research. We would also like to thank LabRoots and our sponsor, T2 Biosystems, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.